Assalamu alaikum. Good evening, everyone. My name is Shireen Al-Fulani. I'm the Medical Science Liaison for Adhd Nutrition Saudi Arabia. On behalf
Recording in
of all of my
progress.
colleagues in
This
Adhd
meeting is being
Nutrition,
recorded.
I'd like to welcome all of you and thank you for your attendance. And I'd like to thank King Abdulaziz University Hospital Organizing Committee for giving us this great opportunity to be with you today. Today, we will start our two-night webinar with a presentation for Dr. Basma. Dr. Basma Al-Jabri, she is an assistant professor, pediatric neurodevelopmental movement disorder consultant, and the deputy chairman of the Department of Pediatrics. Dr. Basma will talk about attention deficit hyperactivity disorder, and then I will be presenting to you the role of nutrition to support brain development in infants, and then we will have Q&A part or discussion, so you can add your questions in the chat box. Now, Dr. Basma, you can start. The floor is yours.
Thank you so much, Dr. Shireen. My extended thanks to the organizing committee and Eventual for their invitation. It's my pleasure to be with you today. As mentioned, I will be talking about the attention deficit hyperactivity disorder. Is the slide visible to everybody?
Perfect.
Okay. طيب بسم الله الرحمن الرحيم والصلاة والسلام على أشرف الأنبياء والمرسلين نبينا محمد وعلى آله وصحبه أجمعين. Our objectives from this presentation is going to be familiar with the characteristics of the ADHD, to understand the components of the diagnostic process of ADHD, and to know the different approach to management, and finally to be aware of the natural history and the outcomes of this disorder. ADHD is a very common disorder among children and also adults. So part of our community awareness is to educate parents, teachers, and also physicians about the ADHD. Before I talk about ADHD, let's start with the common scenario that I receive in my clinical practice. Our case is about GA. She's a 10 years old girl who lives with her parents and her younger brother SA, who is 7 years old. She attends grade 5 in a local school. Her parents were concerned to hear that she has been struggling with homework and her grades have fallen significantly behind in some subjects. There have been some difficulties in friendship, and GA also have been always involved in arguments with her friends and classmates. On a positive note, she's doing exceptionally well in physical activities, as she is engaged in many sports on a daily basis. Furthermore, her parents have noticed that GA is restless, has forgotten her stuff at school, such as the lunchbox or the school equipment. She also has been described as a daydreamer and late in leaving the house for any activities for school or for social events. She's often restless and found it difficult to stay focused or to concentrate, even on things that she enjoys or likes. She described it difficult to stay focused and sit still to watch a movie through. Her mother described herself, mom described herself, being the same as her daughter till now, and she has never been worried or concerned about herself. So a question to the audience: do you think that GA has an ADHD? Yes or no, or I'm not sure. We need further detailed information about her history or not. From such presentation, from the information we had from the parents in the interview, do you think this is enough to say GA is having ADHD? Okay, so we had one answer, not sure. Any other answers? Yes, she does. Okay, not sure. But To be honest, this is not enough to get a confirmed diagnosis of ADHD. We should do further assessment or detailed assessment of other components in the history and physical examination. We'll come through it now. Before we label the child to have an ADHD or we make the diagnosis of ADHD, we must rule out any other conditions or health problem that is similar to ADHD in the presentation, like poor concentration or hyper or hypoactivity. We have to know other components in the history, the developmental history. Was the child up to age in her development? Was she achieved all her milestones at the right time, or was she delayed? As you know, the domains of development that we assist children include 5 items: the gross motor skills, the fine motor skills, language and communication, cognitive skills, social and emotional. Children with ADHD, usually they do not have developmental delay, neither in any component of these domains. They have to be normal or typically developing children. So regarding our patient, in early developmental milestones, she was a very busy child, but that had never been a problem for her parents, as they are both very active people. They believe that the child is similar to her parents. She didn't sleep particularly well as a baby and still find it difficult to settle down when she goes to bed. So this child has difficulty to fall asleep and to maintain her sleep. So basically she has insomnia. Regarding the school history, again, it's very important because some children with ADHD, they may present with learning difficulties or school struggling or learning problem. So we have to make sure that the child is not having this as well with her presentation of ADHD. So in regards to our case, GA never had a problems at school. So the concerns of the parent now at the age of 10 years, it's something acute because they presented when she is 10 years old. She never repeated a grade, although she is not an A student. She always managed to meet the expected level. She finds it difficult to concentrate. She always misses instruction given by the teacher. So it's a common or a chronic or that's her usual during school. The clinical observation in the clinic, she struggles to sit still. She used to fidget and move around in the chair or around in the clinic. The mother admits that this is normal for GA and that it has always been difficult to retain her attention for more than around 10 minutes at a time. So that's her usual, and parents are not concerned, unfortunately, because they believe this is normal and she's similar to her parents. She became embarrassed and hesitant to ask for help because they keep calling her or naming her as she's not listening or not obeying. So that's make her embarrassed and shy to ask for help. So in summary, this child has 2 problem lists: a social issues and a cognitive issue. She has trouble making friendships or maintaining her friendship because she's argumentative, if you remember what we mentioned earlier in her presentation. And on the cognitive side, she had a declined academic performance. She has been described as restlessness, and we witnessed that in the clinic. She also has poor concentration and poor organizational skills. She's always late in leaving house. She always find it difficult to maintain her concentration even on things that she enjoys, like watching a movie. So before we say this child has an ADHD, we should rule out organic causes that are similar to the presentation of ADHD, similar in hyperactivity and similar to poor attention or poor concentration. So before we say this child has an ADHD, I have to rule out any hearing or visual problem. We should make sure that the child is hearing well and seeing things well, because children, they are not similar to us adults. We can recognize the visual problem, that we can comment like it's hazy, I cannot see a clear picture, it's far, I cannot say it clear, or we can describe tinnitus or dizziness very well. Kids like 6 years old or 7 years old, 10 years old, they cannot know this feeling and they do not describe it well as we do as an adult. So it's must for us to exclude hearing problem and vision problem because they will act behaviorally rather than describing that. So the child will have, if the child has a problem or hearing or vision problem, they will act behaviorally. So they have a trouble in school, they do not want to go to school, or they become aggressive, hyperactive, or not engaged socially. So any behavioral problem, one of them is ADHD, it's a must to rule out vision and hearing problem. One of the common differential diagnoses for ADHD is seizure disorder, and the commonest type that is similar to the inattention is absence seizure. Usually, children with absence seizure picked up at school. Teachers, they pay attention to them that suddenly they stop talking or stop uh, making focus with them, and they deviate or they see eye deviation for a few seconds, and then they continue what they used to do. Like if they were talking, they would continue talking or writing or whatever. So a similar presentation for inattention is absence seizure that we have to rule it out. Simply in a clinic base, we do hyperventilation test, not necessarily EEG. You can do hyperventilation test. If it is positive, the child will start to have eye deviation or stop talking or delayed in response to your question. If this is the condition based on your assessment, then you have to refer the child to a neurologist before labeling him as an ADHD. Lead poisoning, in the old days, old houses, all where they had the old painting or pipe, we tend to see lead poisoning cases who present with inattention, but nowadays it's not that common. Thyroid dysfunction, uh, when we have hypothyroidism, children may present with inattention. Hyperthyroidism, they present with hyperactivity. So before we say this is an ADHD case, we must do thyroid function to rule out hyper or hypothyroidism. On the right side of the slide, you see a child sleeping on the stairs. So sleeping problems, either the duration of sleep or the quality of sleep. It's really important for children to become focused, attentive next day in school, or having a good activity level. So before we diagnose an ADHD, it's a must to ask about the sleep history. Do they sleep well? Do they fall asleep easily within 15 to 30 minutes? How many hours of sleep they take? And when they wake up in the morning, how is the mood or the quality of activity? All these questions reflect the duration and the quality of sleep they take, and it must reflect very well on their activity and attention next day. If the child does not sleep well, snore, or duration of sleep is less, or he's restless, or interrupted sleep, we must fix his sleep, maintain it, retain it back to normal, then reassess the child again for hyperactivity. And the last two pictures here, the two characters from the cartoon Inside Out, depression, sad, or anxiety. So with anxiety, you cannot maintain your attention or focus very well because you're distracted, anxious, you have fear. And here, depression, also you cannot focus or maintain your attention. So we have to rule out psychiatric illnesses, commonly depression and anxiety. Depression is, we don't see it frequently in children, but anxiety, yes. So these are the differential diagnoses of conditions similar to ADHD. Here is the difference between the ADHD and anxiety. Anxiety is excessive worry, irrational fear, irritability. We tend to have unexplained somatic pain, headache, shoulder pain, stomachache, muscle tension. ADHD, we have a chronic issue of inattention, disorganization, carelessness, forgetfulness, avoidance of mental effort. The overlap between the two conditions usually in the distractibility, the difficulty in concentration, the restlessness, poor performance, poor sleep onset, hyperactive or excessive response to situation. Sometimes there's overlap or comorbidity, both ADHD and anxiety present together. We can see a video for cases with ADHD, if you allow me for a few seconds.
Don't count or estimate. Less than 20 was showing more than one. 20, okay? What do you think? What do you think, Andy?
So in the previous video, you can notice a child who's not engaged in the activity, and similarly here, he's kind of away from the group. Here, the teacher jumped in and uh, assist the child to stay still and engaged with the other children and their singing the national anthem. I want you to see it, such a child in their daily activities, such as eating. So here is the second one. He had a piece of his pizza, then he stand out, went to play, then returned back to have a sip of his soft drink. This is one example. We see another example. So we have an interview with two children. I will ask you to tell me which one do you believe he or she has an ADHD.
Grade are you? First grade. First grade? Do you like school? Yeah. Why do you like school? Because I like to play with my friends at recess. Why don't you like school? Because I have to do a lot of stuff and my little sister's really cute and I want to spend more time with my little sister. How long does it take you to do your homework? A long time or a short time? Maybe 5 or 10 minutes. I don't know, sort of in the middle. Do you have a hard time with your homework? Sometimes. How do you do on tests? Good. Well, I usually get A's, but not A pluses, so I don't know. And I almost get every single one.
Well, aren't you still proud of yourself for getting A's?
I don't know, I just feel normal.
You just feel normal. You don't feel proud of yourself.
No, I feel normal.
Okay. So do you have a lot of friends?
Yeah. No.
How do you feel about having a lot of friends? How do you feel about not having a lot of friends?
Lonely.
Do you get invited to parties?
Yeah. Not usually.
Do you ever get bullied?
No. Sometimes.
Do you think you are smart?
Yeah. I don't know.
Do you think you are handsome?
Yeah.
Do you think you are pretty?
Sometimes.
What do you like about yourself?
How smart I am and how good I draw. I like myself because as I like Jesus and God and they're really important.
Is there any?
Like, which child do you think he has an ADHD or she has an ADHD, the boy or the girl? Okay, excellent. It's the girl. Do you know why it's the girl? What did you get from her answer? Or by observation while she's sitting on the chair? But it's mainly the girl who's having the inattentive type of ADHD. But she was like moving around, not that much in her chair. She wasn't maintaining eye contact with the speaker. Her answers were kind of sidetracked, not focused, not focused on one idea. She doesn't have an insight and she has low self-esteem, like she's not confident in herself, similar to the boy. Like ADHD, when we speak about ADHD, the presentation is mainly has three components: the inattention, the hyperactivity, and the impulsivity. Usually, we speak or the hyperactivity and the impulsivity always combine together. We have an hyperactive child. Usually, he is impulsive, but the inattention mainly it's inattention by itself, no similarity or combination with the impulsivity. We have three types, either the inattentive subtype, the hyperactive impulsive subtype, or the combined type when we have all the three symptoms together. So ADHD is a complex neurodevelopmental syndrome that presents with persistent patterns. So it's not situational. It is not episodic in one environment. No, it should be persistent, at least 3 months of presentation or more. The persistent pattern of inattention and or hyperactivity and impulsivity. This presentation or these symptoms must interfere with the function and development of the child. Usually the function of the child is play and academic performance in school. So the hyperactivity or the impulsivity or the inattention must impair or have a negative impact on their school performance and their function in playing and making relationship with other people. The symptoms must be present prior to the age of 12 years of age. So the onset of the symptoms or the picture of ADHD must be present before the age of 12, not after, not the onset of the symptom. If the symptom present after the age of 12, this is something else rather than ADHD. We talk about psychiatric illnesses, personality disorders, mood disorders, but not ADHD. Sometimes we diagnose people after the age of 12, like in their adolescence period or adulthood. Yes, we can do that in taking in consideration the presentation of the symptoms during the early childhood or developmental years. So I hope this point is clear to you. Yes, we can diagnose them late when they present to us late in the clinic, but very important to make sure that the presentation of the clinical pictures or the symptoms are prior or present before the age of 12 years. So the other question that we hear, when we can diagnose children with ADHD, we can diagnose them with the age of 4 years, not earlier than that, because kids who are like 2 years or 3 years of age, they are active by nature. They want to explore the environment. They want to see what's above or beyond or behind the furniture, the window. They have to explore their environment. But if the presentation is kind of making a problem to them, danger to themselves or harming themselves, at that time, 4 years of age, we can give the diagnosis of ADHD. Plus, the symptoms must be present in 2 situations or 2 environments. It's not only the home, not only the schools. The ADHD or the hyperactive or impulsive or inattention must be present in home and in school. The symptoms are not explained by another mental disorders, not explained only by anxiety, mood disorder, or personality disorder. Symptoms of hyperactivity, it's in Arabic, so impulsivity. The child does not think what's the consequences of the step or the movement that I will do. So they do danger, they touch electricity, sharp objects, and for example, they cross the street without paying attention to the car crossing the street or the red light or green light. They are talkative, they talk loudly, they interrupt others, they argument a lot with others, and also they interrupt the question before its end. Usually they tend to answer before the teacher finishes its question or his or her question. Usually they fidget or squirms in their chairs. They are moving constantly in their chair, or playing with an object in their hands or playing with their hair. So always busy even when they are sit still. Always on the go, they move like an engine. They are loud, active, they hurt themselves, they hurt the others, and they cannot stay still in one place. The symptoms of inattention, daydreamer, they always stay unfocused or lost attention. If they are in class, if someone is talking outside, they get sidetracked or inattentive or pay attention to that person outside. Or if they sit next to the window, they are distracted by birds or the plane crossing. They are disorganized, messy when they sit and do their homework, or when they sit and play, or they always forget their stuff at school or any place in the house. They cannot stay focused if they are doing a task or homework. They are easily distracted. They do not maintain a track of attention or thinking. And usually they find it hard to start a task. If, for example, if we ask them to do their homework or to start reading, they start to complain like, I'm hungry, I want to go to the bathroom, or it's hard, or I do not like school. So to start a task, it's always difficult to them. So any mental effort that requires attention, initiation of attention, maintenance of attention, or inhibition of other distractors, it's difficult for people with ADHD. Here's the DSM-5 criteria, the Diagnostic Statistical Manual, the 5th edition for the diagnosis of ADHD. For children, we need 6 symptoms out of 9 for the inattention, and 6 symptoms out of 9 for hyperactive impulsive subtypes. If the child scores at least 6 here and 6 there, this is the combined type. At least 6 in the inattentive subtype, he will get the diagnosis of the inattentive subtype. If he gets 6 at 6 in the hyperactive impulsive subtype, you will get the diagnosis, taking in consideration in both environments, in home and in school. Subtypes, as I mentioned them earlier, the prevalence of ADHD is 7 to 10% in kids in USA, usually diagnosed with ADHD, 5% worldwide, 6% in males, 3 to 1%, and 40% of the children with ADHD, they continue to have the symptoms in their adulthood. The etiology of ADHD is due to either genetic causes. When we diagnose a child with ADHD, 50% one of the parents have these symptoms when he was a kid, and 25% one of the siblings will have the same presentation. Environmental, those who are premature, who didn't complete a pregnancy duration of 9 months, or IGR children with birth weight less than 2.5 kilogram. These two factors are risk factor to have ADHD later on in life. Those who are had a brain injury or had meningitis or encephalitis in any time during their life, they will present with symptoms of ADHD. And a clear point to be addressed here. So if the onset is before 12, we give the diagnosis of ADHD. If it's after 12, they may behave or act like symptoms of ADHD, but we not give the diagnosis of ADHD because it's a clear pathology like road traffic accident, for example. Neurochemical, so the theory behind the ADHD is the deficiency of norepinephrine and dopamine in the frontal lobe. So the neurotransmitters, these two neurotransmitters are deficient in the frontal lobe, and they are responsible for maintaining the attention, inhibiting reaction, like impulsivity and the hyperactivity. And this is the theory that we used the medication based on to treat the symptoms of ADHD. The sequelae of ADHD later on life. So children with ADHD, they have academic limitation, they have difficulty in relationships and making friendships. They have a low self-esteem, as you saw in the video for the girl. When they become adolescents, they're more prone for injuries, self-injuries or car accidents. They're more prone to smoking and drug abuse. They're more prone to motor vehicle accidents. They're more prone to get in trouble, legal difficulties, and making crimes and go to jail. And when they are adults, they have difficulty in finding a job or maintaining a job and maintaining relationships. How we diagnose ADHD? It's through clinical assessment, detailed history, detailed clinical examination, ruling out organic causes, the slide of the differential diagnosis that I presented earlier. Observe the child in the clinic, see the symptoms of hyperactivity, hyperventilation test must be done, and then ask for teacher's observation and do the ADHD rating scale. I will talk about the rating scales later. Most common comorbid conditions we observe or encounter with children with ADHD, conduct disorder, 25% of those with the combined type of ADHD tend to have conduct disorder, disruptive mood dysregulation disorder, anxiety disorder, major depressive disorder, specific learning disability, and this is around 40% of children. They present to us with school difficulties, mainly reading disorder. Oppositional defiant disorders, 50% of children with combined type of ADHD have ODD, and 25% of the inattentive type of ADHD they present with ODD. The rating scale, the most commonly used is the Vanderbilt, and we're lucky to have a standardized validated Arabic version of Vanderbilt. As you can see, we have a copy for the parents and we have a copy for the teacher. Clear? All the symptoms of DSM-5 of the inattention and the hyperactivity impulsivity are present. So these are the symptoms or the questions. It reflects the inattentive type of ADHD. And if the parents circle or tick number 2 or number 3, this is the positive. If it's 1 or 0, this is not significant, so we don't count this. So any positive sentence, either 2 or 3, is counted as 1. So this is 1, 2, 3, 4, 5, 6. This child's called 6 symptoms out of 9 for inattention, so it's positive for inattention in one environment. Here are the symptoms of hyperactivity. We have only one positive symptom or a question here, so he scored or she scored 1 out of 9 for the hyperactive impulsive type. So this is not positive or not considered as hyperactive impulsive type in one environment. Also, this type of questionnaire, the Vanderbilt, has all the comorbid symptoms or comorbid condition of ADHD included in the questionnaire. The ODD, or the oppositional defiant disorders, we have these symptoms from 19 to 26. If the parents or the teacher check 2 or 3 is a positive. If they scored 2 or 3 out of on 4 questions is considered positive for the ODD. So it must be 4 questions. For the conduct disorders, must be positive in 3 questions, again in 2 environments. And for the anxiety and depression, again 3 questions, must be positive. The school performance or specific learning disorder also is included in this questionnaire. So if the parent or the teacher tick number 4 or number 5, this is the positive symptoms for learning disability. Only one tick on 4 or 5 is considered positive for reading disorder or learning disorder in general. What is the prognosis of ADHD? So if we diagnose a child with ADHD, what's the lifelong outcomes of this presentation? So 40% of children with ADHD persist into adolescence and adulthood. With age, the hyperactivity decreases, the inattention, impulsivity, the disorganizational skills, and relationship difficulties persist in their life. The treatment, when we treat children with ADHD, we keep certain goals in our mind that we have to counsel the parents about it. Our target from treating ADHD is to improve the school performance, such as in the case scenario that we had in our presentation, to promote safety, especially for those with hyperactivity and impulsivity who injure themselves, to increase the independence, to improve the self-esteem, and to improve their relationships with others. The treatment modalities we have, the medication, the behavioral therapy, or the combined. Based on the research and literature review, the medication is the best modality to treat children with ADHD. It has better outcomes, especially when it's combined with behavioral therapy. Behavioral therapy alone, the outcomes usually less than the medication alone or when it's combined with medication. So by using the medication, we decreases the hyperactivity and impulsivity, and we improve the inattention. The available medication, we call them stimulant and non-stimulant. The Strattera is not stimulant. The stimulant, it's like Concerta and Ritalin. We call them محفزة وغير محفزة because parents used to be afraid from the terminology of المنشطات addictive medication. So the stimulant is the most effective treatment. It's commonly prescribed, reduce the symptoms of ADHD up to 90%. It equally works in all types of ADHD that combine the hyperactive, impulsive, or the inattentive. An example of stimulant medication, the methylphenidate, amphetamine, Concerta, and Dexedrine. The side effects commonly observed with stimulant medications is decreased appetite, headache, abdominal pain, or sleep problems, and those are kind of periodic, not persistent all the time, usually in the first 5 to 10 days on starting the medication. Non-stimulant medication, 10 to 30% of ADHD cases will not respond to the first line, the stimulant, or they develop side effects. We shift them to non-stimulant medications such as atomoxetine, antidepressant, or alpha-2 agonist. It's beneficial for kids with comorbid condition, and the common side effects we observe in these medication is GI upset or irritability or agitation. Behavioral therapy, usually we educate the parents and the teachers how they deal with such children to use simple requests, avoid excessive talking or giving excessive instruction at once, give simple tasks, simple sentences, and wait for the child to do what is requested, then give the other task. Provide regular breaks for release of energy. It's very hard to keep such a busy, active child in chair long time for 45 minutes of a period during class. So give a break every 15 minutes for 5 minutes to release the energy. Ask them to bring any help or support from other classes or from other colleagues. Regular positive attention. These kids very eager and very responsive when we praise them or we give them positive attention. So we advise the parents always talk positively about your kids. We ask the teacher to praise them in the class for their positive behaviors. This kind of behavior will motivate them to do better. Give redirection back when you see the child unfocused. So if you see him inattentive or being distracted with something outside the class, you just tap his shoulder or you knock the table just to bring his attention back to task. Such children with ADHD, it's better to place them seated at front of the class and keep eye contact when spoken to, rather than seating them at the back of the class or next to the door or next to the window. So we're going back to our case. This is her problem list. This is the DSM criteria on a Vanderbilt questionnaire. The teacher version, she scored 6 out of 9 of 0 for hyperactivity, and there was her parent version of the questionnaire, she scored 7 out of 9 for hyperactivity with comorbid condition. So you think this child has an ADHD predominantly inattentive type. Both symptoms were positive in 2 environments. We started her on Concerta, 18 milligram, because this is the suitable dose for her age. And then we have to evaluate the child after 1 month, looking for the side effects and compliance to medication and her response to the medication. In summary, ADHD is a neurodevelopmental syndrome that presents with inattention, hyperactivity, and impulsivity. The symptoms must be present in 2 situations and must interfere with the function and the development of the child. We have different modality of management, and we discuss the outcome of the disease along with the common comorbid condition. Thank you so much for your listening.
Thank you so much, Dr. Basma. Really, thank you for this great and informative presentation. Actually, we're still receiving many questions, but we will keep the answer till the end. Now, I will talk in the next 15 minutes about very interesting topic about brain development and nutrition. We will start with brain growth in infants and young children, important nutrients for brain development like DHA, lutein, vitamin E, and the power of 3 nutrients in breast milk and the formula. Actually, there are many studies showed the huge rapid brain growth during infancy. Can you imagine that brain volume doubles during the first year of life? Also, 74% of newborn energy intake go to fuel the brain growth. 700 new neural connections are forming every second in the first few years of life. And 90% of brain development happens before age of 5 years. So proper nutrition is very crucial to support the rapid growth happens during this critical period. So what are the nutrients, the important nutrients needed to support neurodevelopment or cognitive development? Many nutrients like lutein, vitamin E, DHA, iron, iodine, zinc, choline, and vitamin B complex. I will focus today on the first three nutrients, lutein, vitamin E, and DHA. Next, please, Khalil. Okay. As you know, essential fatty acids as linoleic acid and alpha-linolenic acid must be obtained from the diet because they are essential fatty acids. So if the baby on a breastfeeding, he will receive both of them because they are present in the breast milk. But if the baby is on the formula should be supplemented with those essential fatty acids. What about DHA and the AA? DHA and AA are long-chain polyunsaturated fatty acids, make up the crucial parts of the cell membrane, especially in the brain and retina. But the infant body can synthesize DHA from omega-3 and AA from omega-6. DHA is playing a very important role to support brain and eye development because it represents around 97% of omega-3 fatty acids in the brain, and it makes up to 91% of omega-3 fatty acids in the retina. Now, what can affect the absorption of DHA? Next, please. Fat blend is very important factor. You can see here the difference in fat absorption between two formulas. One formula without palmolene oil, this one with the blue column, and the other formula with palmolene oil. This is the gray column. This is a Nelson study. Okay, it concludes that the fat absorption is lower with the palmolene oil formula when compared to the formula without palmolene oil. Okay, in order to understand more about the palmolene oil story, let's see here the difference in the triglycerides structure. You can notice on the left side, we have the triglycerides in the human milk. You can notice here that the palmitic acid is present in the position number 2, SN2 or beta palmitate. On the other side, we can find that the triglycerides in palmolene oil, palmitic acid is present on the position number 1 and 3. Okay. During digestion, the pancreatic lipase can break the linkage or the bonds on the position 1 and 3, but position 2 is still resistant. So in the breast milk, the palmitic acid will be easily absorbed by forming micelle, but the problem here with the palmolene oil triglycerides, because the palmitic acid will be binding with the calcium and form calcium palmitate soup. This soup will be secreted in the stool, and so it will affect both fat absorption and calcium absorption, and also it will lead to hard stool. Another study to show the effect or the bad effect of palmolene oil in the formula, this is the Souza study, which showed that palmolene oil-free formula have 6.5 more times DHA absorption here because the stool loss of DHA is less in the palmolene oil-free formula compared to palmolene oil formula. Now the second important nutrient for brain and visual development is lutein. What is lutein? Lutein is carotenoid. Okay, these carotenoids are mainly orange or it's fat pigments which give the color to the plants as tomatoes and green leaves. Research demonstrates that some dietary carotenoids can provide good positive health outcomes, especially with some diseases like cancer and eye disease. The carotenoids that have been most studied in this regard are lutein and zeaxanthin. Okay, how can we get lutein? Over 600 carotenoids are found in nature. We can consume around 50 carotenoids in the diet, and 20 can be found in the blood. But only two carotenoids can reach the eye, lutein and zeaxanthin. Okay. We can notice here that the concentration of lutein is 1,000 times greater in the eye compared to the plasma level. So lutein is very important to support the visual development. How can the lutein support eye health? Actually, the mechanism, there are two ways for the mechanism of action for lutein. Lutein can absorb the blue light, so this blue light can damage the retina, and also lutein can protect against the oxidative damage, so it will stabilize the eye cell membrane. So lutein, next please, Khalid, absorb the high energy blue light and can protect against oxidative damage. So lutein is concentrated in the eye, especially in the macula, and the emerging evidence now indicates a role of lutein not only for the visual development, but also for the cognitive function in adults. Okay. On average, mature breast milk contain around 60% less lutein than colostrum. The fact that lutein content is so high in the colostrum, you can notice here, this is the colostrum contain higher level of lutein compared to the mature milk. You can see here the concentration of lutein, okay, over this period, it decreased starting from the colostrum till reach the mature milk. But we know the infant is still consuming a greater amount of lutein, so he will be receiving a good amount. Okay. This study showed that although the infants on average started their life with the same lutein level, you can notice here the difference in the breastfed babies, and after 1 month they will have higher concentration of lutein. But on the other side, you will notice that the formula fed babies started with lutein, but after 1 month, if they are taking formula without adding lutein, they will have a lower concentration or lower blood level of lutein. So lutein addition in the infant formula is very important. This study from Adhd study, this demonstrates that babies fed our formula with added lutein had a plasma level within the range of breastfed infants. And this is our goal, to make our formula closer in the composition and physiological performance with breastfed babies. Lutein was found to be the predominant carotenoid present in 4 regions or 4 areas in the brain: auditory cortex, frontal cortex, occipital cortex, and hippocampus. So the emerging signs suggested that carotenoid may play a role not only with the visual, but also with the cognitive development. Lutein helps make up the macular pigment. This pigment in the eye can be used as a biomarker to the lutein amount in the human brain. And the studies have been done to show that higher amount of lutein in the eye means higher amount of lutein in the brain. So this allows for research that can better help us to understand the relationship between lutein and the brain development and function. This is the Renzi study. It showed that the relationship between macular pigment and processing speed, and the result showed that increase in the macular pigment density was associated with the significantly improve in the processing speed. Finally, this is another study done by Bouvier and published in 2014, demonstrated that higher lutein level help speed up brain connections by 12%. Now let's talk about the third important nutrients which support brain development in infants is natural vitamin E. Vitamin E is an essential nutrient, and there are 2 forms of vitamin E, tocopherol and tocotrienol. The active or the most active form is alpha tocopherol. Okay, alpha tocopherol has 8 isomers based on the rotation around 2, 4, and 8 carbon position, clockwise or anti-clockwise. They are 4 starting with R and the other 4 isomers starting with S. But they found that the isomers starting with R, they are the most active 4. Okay, RRR is the most active form, and we will know now why it's the most active form. It represents what 100% of the natural vitamin E. We are calling them D-alpha tocopherol. But the synthetic vitamin E containing the 8 isomers, either the isomers starting with R or the other 4 starting with S. Now, why the RRR is the most active form of vitamin E? RRR is the master K for alpha tocopherol transfer protein. You can notice here it is the only one that can work with this transfer protein. What the role of this alpha tocopherol transfer protein? It can move the vitamin E to reach the liver cells, where it can be incorporated into new created very low density lipoprotein molecule, and this convey alpha tocopherol to cells or to the cells in the rest of the body. Natural vitamin E is present in human milk, and it's preferable to be added to the formula. So Abbott was the first and the only company who added natural vitamin E to the formula. The previous one, please, Khalid. Okay, here we can check the label if you want to know, if you want to check the formula, if it's containing natural vitamin E or synthetic. The natural vitamin E will be written on the label by this form, D alpha tocopherol or RRR alpha tocopherol. But the synthetic form of vitamin E will be written at this form, DL alpha tocopherol. So you can differentiate easily between the formulas with natural vitamin E and synthetic vitamin E. What is in breast milk to help to protect DHA? Actually, these nutrients, next please, are all also present together in breast milk. Vitamin E, lutein, and DHA. But we talk already about DHA, and we know that it's easily degraded or faced oxidative degradation. So we need to add some nutrients like vitamin E and lutein to protect DHA from oxidative degradation. Finally, this an in vitro study showed the average of number of neuron cell branches. It was higher with DHA, lutein, and vitamin E compared to DHA alone. So they found that 81% more brain connections with adding the 3 nutrients together, DHA, lutein, vitamin E, compared to the presence of DHA alone. As a conclusion, brain development is very rapid during the first year of life. Nutrition plays an important role in the brain development, like we discussed. Palmolene oil formulas is scientifically designed to support absorption of key nutrients like DHA, lutein, vitamin E. Studies showed that the presence of lutein and natural vitamin E enhanced the effect of DHA on brain connection. Thank you. Now this is the time for the questions. Dr. Basma.
Yes, Amara.
You ready? Okay. The first question, Dr. Basma. Thank you, Dr. Basma. ADHD can be delayed presentation until late adulthood, if yes, in the form of what clinical features?
In the form of what, sorry?
The form of clinical features. What the clinical features if this ADHD appear late adulthood in the adults?
The symptoms must be present early on during their childhood, early developmental years. This is very important to make the diagnosis even when they are if they get the question right. So what is the replacement for the teachers? Usually the co-workers, the friends, the relationship, the marital relationship, like the people around this adult. Do they complain from his behaviors, or he has difficulties during work, or difficulties with their relationship?
Okay, thank you, Dr. Basma. The second question, can autism in early age, 3 to 5 years, be mistaken for ADHD in attentive type?
Like, let's make it very clear. The presentation of autism is different than the presentation of ADHD. So it's not should be mistaken, but unfortunately it's misdiagnosed. Right? In order to say this child has autism, we have poor communication skills, we have repetitive behaviors, patterns, certain activities, or motor mannerisms. Sometimes children with autism have a comorbid condition of ADHD or hyperactivity. So they present, or the parents would present to the physician with a complaint of hyperactivity. But as a physician, I must make sure that the domain of developments, if you remember one of the slides, is to check the development. ADHD children, per se, like ADHD, simple ADHD, they do not have a problem with communication, they do not have a problem with language, they do not have a trouble with social relationships. As you know, autistic children, they have poor social skills, poor communication skills, they have repetitive behaviors or patterns. So yes, in some certain situation, but the physician, the qualified physician, able to differentiate between autism and ADHD. Sometimes, yes, they present to us as hyperactive, but during the assessment, it's an autism, and we deliver that to the parents clearly. It's autism plus an ADHD. Okay.
Thank you, Doctor. Okay, from the video of the ADHD screen, could be the screen time will increases anxiety and ADHD symptom for the girl and the boy video. And another question related to it, Doctor, late diagnosis could be due to negligence, and when can we introduce medications?
So it's three components in one, three questions in one. Do screen and anxiety make the symptoms of ADHD worse? Does she mean, or does he mean like watching electronics or TV for a long time? No. Does not make the symptoms of ADHD worse. Usually, staying long hours on electronics will impair the sleep quality, like the sleep onset, I mean, sorry. Will make the social skills and language skills not that much good, but not the symptoms of ADHD or the symptoms of autism. The other one, what was the other component, the second component of the question?
Late diagnosis could be due to negligence.
I don't say negligent, but you know, most of the families in our community, they tend to deny, especially when we are afraid from the social stigma, and when we are afraid to use such medication. We tend to hear commonly from the parents, no, my child is okay, he's smart, he's doing well at school, we are not going to treat, and it's okay for us, we can tolerate such hyperactivity or such trouble with inattention. Because again, it's the social stigma and the use of the medication. Negligent, maybe, yes. Sometimes it's late to diagnose because they do not believe it's a problem. The other component is related to the medication. Once we diagnose ADHD, we should start medication, especially if there's an impairment in school performance or problems with friends or family. So if the academic performance is impaired or we have a social problem, it's a must to start the medication.
Okay, thank you, Doctor. And when can we introduce medications?
As soon as we diagnose age. Or the better outcomes.
Thank you. Okay, doctor, the next question. Any kid who is diagnosed with ADHD under the age of 2.5 years, do you think that kid need to go again for assessment after 4 years of age?
Like, we do not diagnose ADHD in such young age. ADHD diagnosis must be 4 years and above. It's normal development to be moving around, exploring the environment. We cannot label a 2 years old, a 2.5, or a 3 years old to be hyperactive. This is not proper and not like official.
Super
No,
age.
it's 4 years and above, not before that.
Okay. How can we convince the parents to give stimulant to their children?
So I usually do in my counseling to the parents to ask them what's their main concern or their main reason to come to seek medical advice. And that's number one, to remind them why they present to us. Number two, especially if we have a complaint for the school or the performance at school is declining or getting worse. That's number two. Three, especially for those hyperactive, and if we have safety concerns, sometimes they come with frequent injuries or traumas. We tell them, try it, at least give it a trial for 1 month and let us see after 1 month, do these symptoms of presentation get controlled, get less, you're able to to have a good time with your child, to pay less effort as a parent, to pay extra attention or extra care for such an hyperactive child, or to pay an extra effort for inattentive one in study. We use the equilibrium with them, try it and then reassess, and you make the decision to continue or not.
Okay, thank you, doctor. Yeah, sorry, but many questions really.
It's okay.
Okay, the next one, doctor, about Concerta. Actually, two questions. The first one, should it be taken daily or stopped during the weekends for avoiding tolerance? And the second one, when should we stop medication permanently?
So the recent evidence from research and literature, it's better to continue on medication all the time during the weekdays and the weekends. The long-term effect, it's better for those who continue to take the medicine on daily basis. Sometimes when we have a hesitant parents or those who are not willing to use the medication, we convince them, especially if the child has difficulty at school, to use it during the weekdays, and for the weekends they can have it off, just for the sake of the benefit for the child, like to have negotiation with the parents. I use such style if they are really hesitant or not convinced to use the medication. So I tell them, try it during the weekdays, especially for school benefit, and the weekends it's off. But evidence-based, it's better to continue on the medicine on daily basis. The part one. Part two, when we stop the medication, if we have a serious side effects, and this is really rare, for Strattera, Ritalin, usually we don't see such serious side effects. For Concerta and Ritalin. For Strattera, rarely we see kids with agitation or irritability, and I would say this is one of the complaints I hear it from the parents, and made us to change the medicine to a different modality rather than to stop totally the medication.
Thank you, doctor. The next question, actually maybe all of the mothers are worrying about this. Is the internet addiction an environmental risk factor for a healthy child to develop ADHD?
No. Staying long hours on electronics, sedentary lifestyle does not cause ADHD or inattention or inattentive type of ADHD, not the hyperactive type. But spending hours electronics, it's not good for their brain, like for thinking, for learning social skills, like to start talking properly on different ages, the younger kids and even those who are teenagers. So limit the screen time to 1 or 2 hours per day, or have it zero during the weekdays, and the weekends they can take it as like free time for them. Try to have sport in their daily activities at least 1 hour per day to make them active and engaged rather than spending hours on electronics. طبعا we cannot say turn off the TV and force them. No, find a replacement. Find something to distract them rather than to turn it off and punish them. No, engage them in certain activities. And this you can decrease or limit the screen time for the children.
Thank you, Dr. Bassem. Is hyperactivity with speaking a lot and not keeping without work or something to do is ADHD in adults?
Alone, we have to do proper assessment in order to say yes or no, it's ADHD or not. We cannot judge on one presentation from one perspective. No, we should ask about the early developmental years, as I presented you, and to ask other people around this adult about his symptoms. But speaking a lot or speaking aloud alone, it's not an ADHD. We have to do proper assessment in order to say yes or no.
Yes, yes. Thank you, Doctor. Doctor, actually, this is a question, I think it's to me, but I need your support
Okay.
also. Please enumerate a list of suitable food for ADHD, list that available for a sample family. Actually, from our side as a nutrition, we don't have a specific formula or specific nutrients can be used with ADHD children because, as you know, Dr. Basma, because every child maybe have different nutritional needs. So our formula is for the maybe we can say normal baby. Actually, don't know how can you adjust this diet, especially for ADHD children.
If you notice, I didn't mention anything related to nutrition in my lecture, and I took specific for ADHD or for autism. It's nutrients, it's for nutrition, it's for feeding, it's for physical growth and of the body and the brain as well. But there's nothing specific in our natural food or in the formulas for ADHD itself. I mentioned again in the presentation, the theory behind ADHD is the deficiency of the neurotransmitters, the dopamine and norepinephrine. And these two transmitters cannot be replaced by just taking food. It's replaced by medication. That's number one. Number two, there's nothing in food can make an ADHD, like the picture of ADHD or make ADHD worse. Some families or parents believe that taking carbohydrates, a lot of sugar makes the child hyperactive. That's a temporary hyperactivity. We all know if we drink coffee or have something sweet, we become alert, attentive, yes, but that's for a short period of time. ADHD is something chronic, long time. It's on daily basis. So this is a simple answer to food with ADHD.
Which means, doctor, you are not eliminating something like carbohydrates or chocolate from your patient's diet.
Yes, we don't eliminate that from their food. To have it in a reasonable amount, but not that much due to the obesity or other side effects related to high sugar diet, but not the ADHD.
Okay, thank you. The last question. 6 months or 1 year babies, the mother giving a mobile to divert or change their attention. 4 minutes crying, if this is good for baby health?
Absolutely not. This is totally prohibited to give such younger age electronics. Any child younger than 2 years old, please do not give iPad, TV, cell phone, nothing. Do not use is to distract such children. No, use the toys, use the stories, books to read to them, any kind of toy to distract them without giving them the cell phone, because the long term, not the long term, like the short term side effect of such electronics is language delay. And we don't want to see such children having such problem.
I'm sorry, Dr. Basma, I promised you to be last question, but
Okay.
the last
No
one
problem.
more from Dr. Tarfa. Is a child's diet considered environmental cause of ADHD?
No.
Not.
As we mentioned earlier, diet has no relation to ADHD. ADHD is a chronic condition. The symptoms must be all the time to imbalance. Diet has no relation to hyperactivity or inattention. The effective diet is temperate, like short duration, not long, not causing comorbid condition of ADHD.
Really, thank you so much, Dr. Basma. Very great presentation. You give us a lot of information. ADHD, I think many of us, we are facing those children. Thank you for this informative presentation. Thank you for your time. And I'd like to thank all the attendees. Thank you and see you again, inshallah.
Thank you so much.
Bye-bye. Assalamu alaikum.